not the press. I will present the main results of our COMPARE study, effect of Losartan on the aortic dilatation rate in adult patients with Marfan Syndrome. So I think Marfan Syndrome requires some explanation. It's a connective tissue disorder affecting multiple organ systems, but prognosis is mainly determined by aortic complications. The aorta being the great vessel arising from the heart, as you can see on the right-sided panel. So gradual aortic dilatation occurs in these patients until an aneurysm develops, and these aneurysms are prone for rupture or dissection, tearing of the wall, as you can see in this image, which is a very lethal event. So many of these patients walk around with their normal lives with a time bomb. And the only thing we can do as clinical management is taking care that these aneurysms will not develop by lowering blood pressure, mainly by beta-blocking agents, and open heart surgery, actually, in which we replace the aortic root. Now, a few years ago, in a mouse model of Marfan syndrome, it was shown that the effects of the mutations which cause Marfan syndrome, which is in fibrillin, actually encoding for microfibrils in the aortic wall, there was a very beneficial effect of an old antihypertensive drug on the market since 1994, probably because it antagonizes overexpression of a substance called TGF-beta, which can have deleterious effects in the aortic wall. You can see the images of the mouse experiment in the lower left panel, in which on the left side you can see the placebo-treated mouse, and on the right side the Losartan treated mouse, and on the lower panel the histological samples. And in these studies, treatment with Losartan reduced aortic dilatation rate and resulted in an almost normal architecture of the aortic wall. Now, people are not mice, and I have no disclosures. So we set up a randomized trial to test the hypothesis if Losartan would be beneficial in Marfan patients with a primary endpoint aortic dilatation rate at any aortic level. So in 3-year times, patients were enrolled from all Dutch Marfan screening centers, and we randomized then putting them on Losartan versus no Losartan, and previously prescribed medication was continued. This was mainly beta-blocking agents. So we assessed aortic diameters with magnetic resonance imaging as inclusion, and after 3 years of follow-up. So we are not talking about thousands of patients here. We had trouble including 233 patients, and as you can see, we ended up with 113 versus 105 patients. You can see an image of the total aortic on the upper right panel, with the aortic root showing here, which is clearly dilated, and here the remainder of the aorta. And in the lower side panel, you can see the operation which is prophylactically performed on these patients, the aortic root replacements. So we had about a third of the patients had already replaced aortic root. So after 3 years of follow-up, we could see a significant difference in aortic root dilatation rate in patients using Losartan compared with patients with no additional treatment. And that was only, of course, in patients with still a native aortic root. But we could also see in patients with an already operated aortic root, we could see a significant difference between controls and those using Losartan in the trajectory just beyond the aortic root and the ascending aortic, the aortic arch, which you can see here. We could not show additional effects here in the remainder of the aorta. So in conclusion, addition of Losartan to standard of care, and that was mainly beta-blocking agents, in adults with Marfan syndrome reduces aortic root dilatation rate. And after aortic root replacement, it reduces aortic arch dilatation rate. Thank you for your attention.
Thank you. This paper is now open for discussion. Questions from the audience?
Ed Sussman, MedPage Today. Did you do any statistical or just looking at outcomes as far as whether treatment prevented events?
Yes. So we have very few events, actually. We are treating these patients fairly good. They are very aggressively operated before the aneurysm reaches a size when it becomes really dangerous. So we had a few events. They will be shown in the session this afternoon, but they were not statistically significant, and I believe that we need much longer follow-up to find real clinical endpoints.
Are most of these patients in your study relatively young patients?
Yes, there are patients between 20 years old and 40 years old.
Other questions? Yes.
Can you give us some, Shelley Wood with theheart.org, can you give us some idea how many of these patients a cardiologist would see in his or her practice? How common are you seeing a Marfan syndrome patient?
Well, this is a very difficult question because the known patients are mostly concentrated in Marfan centers. But it's a very difficult diagnosis, and you cannot see the aorta from the outside. So most of these patients are living generally normal lives, and sometimes aortic dissection is the first presentation of the disease. So the prevalence is thought to be 1 in 5,000, and in our national database we have about 1,000 patients. So there are a lot of Marfan patients walking around elsewhere. We don't know where they are.
And the types of events that you're going to present later, can you just give us some idea what those are?
Main events were prophylactic aortic root surgery or aortic dissection or sudden death. So we had one patient who died, but from a non-cardiovascular cause. And we had similar amounts of prophylactic aortic root surgery, which was about 9 in both groups.
And the dissection?
We had 2 dissections. They were both in the control group.
Other questions? Yes?
Peter Overbeck, Springer Medicine, Germany. Could you tell us about the mechanism behind the effect? Was it a hemodynamic effect by further blood pressure reduction, or do you think it's a specific biochemical effect that you showed at the beginning that was shown in the experimental study?
Well, that's indeed a very good question. So all this time we are treating patients, we have focused on lowering the blood pressure with a multitude of agents, and of course Losartan is, as an antihypertensive agent, lowers blood pressure as well. And we performed analysis on that, and we saw that blood pressure was actually lower in the patients who were using Losartan. But these were not correlated with the degree of aortic dilatation. So I think these are both will help. So it will help to lower blood pressure further, but you should notice that most patients are put on beta-blocking agents already to an extent that blood pressure is really normal or below normal. So blood pressure, systolic blood pressure was about 120 millimeters of mercury, which is normal for these patients of this age. So I think that both mechanisms will contribute to the effect.
There's a question here.
Get the microphone here, please.
Was
Can you identify yourself again,
Bruce
please?
Jansen from Cardiology News. Was Losartan well tolerated, and is there any thought to testing an alternative drug?
Yes, you mean that it might be a class effect of the drug?
Yes.
Yes, we are not sure about that. The mouse experiments have been performed with Losartan. We believe it to be a class effect. And it was tolerated well to a certain extent. We tried to get them all on the 100 milligrams of Losartan, but a considerable portion of the patients could not have that in addition to beta blockers. So then the dosage was reduced to 50 milligrams, and that was about in half of the patients.
And my understanding is a fair number of patients are diagnosed as adolescents. Is it a drug that is approved or reasonable to use in a non-adult age group?
Very good question indeed. So in my belief that the effects on the aortic wall are are caused by the fibrillin defect, but also by wear and tear of repetitive cyclic stress by the heart. So in that perspective, you should hypothesize that the earlier you start, the better it is. But there are other trials running now with children. There has been one trial with a group of children with severe manifestation of Marfan syndrome. This was published a few years ago, and it showed also a beneficial effect.
Other questions? Yes.
Ed Sussman, again with MedPage Today. Are you at a point where you can recommend treatment with Losartan for patients with Marfan syndrome?
Very good question indeed. Well, we had trouble with the inclusion because a lot of patients were already using Losartan because of the mouse experiments. So I think we can be positive about that. I think we can recommend Losartan because, well, most of our patients were on beta-blocking agents already, but we had a considerable portion of patients without beta-blocking agents. And in our sub-analysis, we found that they were equally effective, beneficially effective in reducing aortic root dilatation rate, I must say. So I think that's, yes, you can recommend that.
Yeah, follow-up question?
And one more question: are there any particular ethnic groups that are susceptible to Marfan syndrome, or is this something that crops up sporadically?
No, it is. We are not aware of racial differences. We believe that a lot of persons have had Marfan syndrome. For instance, Abraham Lincoln. Well, he died suddenly, but not of aortic dissection, I believe. But also the Egyptian pharaoh Akhenaton and the piano player Rachmaninoff. I don't know if there are any piano players here in the audience, but it's very difficult to get these chords. You know, so Marfan syndrome is characterized by very long fingers, for instance. So we are not sure, but we have the impression that the disease is equally distributed over all racial groups.
Another question, anyone? Any questions in the back? All right, so thank you.
Thank you.
We'll have Dr. Badiman make some closing remarks.
Yes, I would